The building that Behçet described the disease. So this is the Department of Dermatology, and this is specifically his office. So I'm coming from his own hospital in medical faculty. And as you know, when he described the disease, he described the three main features of the disease: recurrent oral aphthous ulcers, gentle ulcers, and uveitis. And for the first time, he suggested that this combination is describing a distinct disease, an entity. He also discussed the possibility of a viral infection, especially for uveitis, and also the role of focal infection in the oral cavity as a triggering event for disease manifestations. But we later noticed that it is actually a multi-system disease, and it may affect eyes, cutaneous tissues, brain, lungs, vessels, both arteries and veins, also intestinal tracts, joints. The main feature of Behçet's disease is its recurrent nature. So most of these multi-system manifestations are recurrent. They happen, heal themselves, and then they recover. The healing may take days to weeks, for some manifestations sometimes months, but the main feature is spontaneous healing of those manifestations. And most of them are actually leave no scar, like all ulcers. It happens, and it heals without leaving a scar. But some of the recurrent manifestations may leave a scar. And consequently, these scars are causing functional impairment, like visual loss, or a problem in our arteries, or veins, or joints. So these are usually the consequence of the permanent tissue damages resulting from this inflammation. And the other important feature of the disease is it's inflammatory. It is hyperinflammatory. So increased inflammatory response, different stimuli, is a very important feature of the disease. And in inflammation, we have two different systems. The first one is innate inflammation, which is our first defense against microbial or environmental triggers. So Behçet's disease is usually resulting from an increased innate immune response, resulting from, let's say, the production of pro-inflammatory cytokines, inflammatory mediators like IL-1, TNF, IL-8, IL-6, and it's also associated with an increased neutrophil activation, another important innate cell. But this innate hyperinflammatory status is not specific to any pathogen or any other trigger. It can be triggered by trauma, like the pathogen test we do for the diagnosis, just pricking the skin by a hypodermic needle, or sometimes it's spontaneous, like this tooth is behaving like a needle and just causing a pathogen reaction, causing an aphthous ulcer in the tongue. And it can be induced by some dangerous signals, like uric acid. Whenever you induce uric acid into your skin, you can have an exaggerated inflammatory response. Everybody may have an inflammation. For example, on 24-hour, this is the reaction in healthy controls, and this is the reaction in Behçet's patients. But on the second day, since it's more exaggerated inflammatory response, this is the healthy control, but again, high inflammatory response on the second day. So we have exactly the same inflammation. It's a bit uncontrolled hyperinflammation leading to this tissue damage. And we also have another inflammation way, which is adaptive immune response. This is the second line, which is developing after innate immunity, which involves T cells, B cells, and other adaptive immune cells. So in Behçet's disease, we have also evidences suggesting involvement of T cells, mainly cytotoxic T cells like CD8 positive T cells or gamma delta T cells. And the pro-inflammatory mediators they are releasing are also classifying those T cells into subgroups like Th1 type of T cells, Th17 type of T cells, which is actually telling us that these T cells are producing a certain set of cytokines, pro-inflammatory mediators, which is defining the nature of inflammation, which is quite important. And we also know that this inflammatory reaction can be triggered by different viruses or bacteria. So it is not something specific to any virus or any bacteria. Any danger signal or pathogen-associated molecular pattern can induce this hyperinflammatory status by induction of certain receptors recognizing these pathogen-associated molecular patterns or danger-associated molecular patterns. So it's the non-specific activation of the innate and later adaptive immune response. So what happened, or what's happening in the conference, in the doctor's conference? Well, in the first day, yesterday, we started by discussion of the characteristics of this inflammation. The first talk was the general talk about the type of receptors recognizing these pathogen or danger-associated molecular patterns. And also we discussed the mediators released from these inflammatory cells, like IL-1, IL-18. Well, none of them were actually specific for Behçet's disease, but the whole idea was, again, to characterize the inflammatory nature of the disease. I'll tell you why we are so interested in for the characterization of this inflammation, which is quite important to identify the targets for the induction of specific treatments for Behçet's disease. And we also discussed the role of microbiota in Behçet's disease. As I said to you, the environmental triggers, including the microbes, are quite important in triggering this inflammatory response. And we all actually have about 10 times more microbes living on our body. So if, let's say, 100% cell is our body, 10% is our own cells, and 90% are microbes. We are living them with happily. Well, they are actually quite helpful for us. We need them. But the types of microbes, their distribution is quite important. And there are studies being conducted in different conditions, not only in Behçet's disease, in several inflammatory conditions, trying to understand the differences in the distribution of these microbes. Is it the cause of the disease, or is it just resulting from our genetic background? Well, we really don't know whether egg or chicken, which is responsible, but the microbes are important, and there are some differences between the microbial constituents in our oral cavity, in our skin, and other areas. So, Farida Fortune discussed the microbiota of Behçet's disease. And we also had some presentations. The first one was an animal model. It's not directly for the patients, but the second one was a trial, a study investigating the role of acute phase response. Well, these are the biomarkers we are using to test the degree of inflammation. We know that in Behçet's disease, we have inflammation. It is a hyperinflammatory disease. But the area of inflammation is not so big. Let's say all ulcer, maybe 1 centimeter square. While uveitis, which is quite important, may cause blindness. But if you consider the total area of inflammation, well, a millimeter inflammation is causing a terrible condition, visual loss, and other consequences. But the area of inflammation is not so big. So their extrapolation to our systemic circulation, when you give blood to test your level of inflammation, may not be so helpful. So this study was testing the level of inflammation, whether it is helpful to monitor your disease, and how can we improve that sort of biomarkers for disease following. And as a summary for the first part of the talk, maybe the most important thing for you is this increased inflammatory response is somehow associated with changed microbial flora in the oral cavity, skin, and other parts of the world. And also our immune cells, adaptive and innate immune cells, are responding differently to those stimuli. So they have some differences in responses to these stimuli. So we are trying to understand Behçet's disease-associated pathways the cells, inflammatory mediators, what could be the real target, the real pathway that we can use for the treatment, for having an effective and safer treatment for yourself. So in the afternoon session, we had, in the second day, we had the genetics. This morning we discussed the contribution of genetics in Behçet disease. And genetics and epigenetics, which is not directly the sequence of our DNA, but other factors usually associated with environmental triggers, or even when we were in our mother's womb, we may be exposed to certain things, and they all are changing the expression level of certain genes without changing the sequence. We may have exactly the same sequence, but the expression level may change. So we discussed the genetics and also epidemiology of the disease, which is quite important because there are differences in the prevalence rate of Behçet disease throughout the world, which is quite common in the Middle East, in the eastern part of the Mediterranean, but it's quite rare in the Northern Europe, in the Americas. There are some clusters in the South Asia, China, Korea, Japan. Well, it's a rare disease in certain parts of the world, maybe in most of the part of the world, but it's quite common in certain regions like Turkey. So we discussed epidemiology, its background. And I will show you something about its genetics. Well, it is a complex disease, but it has a genetic background. So we have some families with some other members affected. So do you have any family member with an affected, who is your relative with Behçet?
I was only diagnosed in August, and my mum was diagnosed after me.
Okay.
Yeah, and my son is in the process because he's been unwell, but it's not confirmed.
Okay.
I've got it at the age of 17, and my daughter's got it at the age of 6.
My mom used to get ulcers like 30 years ago, and now my daughter gets ulcers also.
Okay. So 4, 7, 10.
I was diagnosed last year. My 8-year-old daughter is experiencing the ulcers in the mouth, arthralgia. It's suspicious.
Okay. Well, it exactly reflects our own series. Well, the familial aggregation, the percentage of patients with a positive family history is changing between 2% in Japan to 18 or 20% in Turkey in different series. And now in this group we have 4 people, and if it is 20 or 25, it's nearly 15 to 20%. So there is a familial aggregation. And also the second clue is its peculiar geographic distribution, which fits very well to the distribution of our main genetic findings, HLA-B51, which was first described by Professor Ono. You heard him this morning. He's an ophthalmologist, and when he was a young fellow during his studies in the States, he described the association of Behçet disease with HLA-B51. It was named at that time A5, later on it was named B5, now we call it B51. Well, it is the main finding. And today I discussed the new method to identify genetic association findings, which is called Genome-Wide association studies, which requires thousands of patients and matched controls. And also another set of patients and controls to confirm the findings you identified in the initial discovery set. So in Behçet disease now we have 6 different GWAS studies conducted in 4 ethnic groups: Turks, Japanese, Chinese, and Korean. And as a summary of these genetic studies, most of them are, again, showing us the importance of HLA-B51. And we don't know how HLA is causing the disease. It may be associated with an adaptive immune response by presenting certain peptides to immune cells, or it may interact with some other innate cells we call natural killer cells, or it may be something related to the folding problems of HLA molecules, depending on the peptide and the peptide properties. The combination of peptide and HLA may cause an unfolded protein response. Any problem in the folding may cause innate autoinflammatory response, and it all depends on peptides. So, as a summary of the genetic findings, now we have several non-HLA genes in addition to HLA-B51, although B51 has the strongest effect, but there are several other genes contributing to Behçet disease phenotype, and I grouped them into two big groups. The first one is the genes encoding proteins responsible for sensing and also processing of pathogen or danger-associated molecular patterns. So some receptors, some mediators responsible for the sensing issue. So we are responding to certain stimuli in a different way, which causes an inflammation. And the second part of the genes are associated with defective regulation of this inflammatory response. So we have a defect in the regulation of innate and adaptive immune response with less production of IL-10, which is causing less suppression of inflammation, or an imbalance between IL-12 and IL-23, which is causing a certain type of polarization of T cells. Well, it is too detailed, but what I can tell you, all these efforts are aiming to identify inflammatory pathways responsible for Behçet's pathogenesis. And whenever we identify these pathways, it's possible to use certain drugs for the treatment of our patients. And currently, at least 3 drugs are being tested for licensing in Behçet's disease, and they all are fitting very well with the genetic findings. The first part is about the sensing and processing of these signals as indicating the role of IL-1 and TNF. So we have now a study being conducted for uveitis of Behçet's disease by an anti-IL-1 monoclonal antibody. And we also know the success of anti-TNFs in many manifestations of the disease. And the other one is PDE4 inhibitors we call apremilast. And phase 2 is recently finished by Gül and her colleagues, which is actually increasing the IL-10 level and decreasing the IL-12 level. Very similar to the pathogenic event, so it's fitting very well with the genetic study. So they may provide us some hints to identify targets. So that was the summary of the genes. But we all know that the GWAS studies, although they all were conducted in total thousands of patients and controls, well, it can explain only a portion of the genetic tendency, because they are just reporting us common polymorphisms. So these polymorphic markers are common in healthy population. There are some differences in the distribution of these common polymorphisms. And they have some functional effect. Their functional effects are small, but since they are quite common in the population, their impact at the population level is quite important. But for the missing part of the heritability, we have some rare variants. For example, in Turkey, we have another regional disease we call familial Mediterranean fever. And the gene responsible for familial Mediterranean fever is also increasing the risk of Behçet's disease. So again, supporting the shared pathways. And copy number variations, so far we don't know any copy number variation, or some epigenetic variations. And this morning we heard a small study reporting some epigenetic changes and its resolution with treatment. And this afternoon, just before coming here, we discussed quality of life and socioeconomic factors in Behçet's disease. Gül will talk more about this issue, I believe. So all these quality of life measures and socioeconomic factors, I think we really need to listen to you more carefully, because you are telling us something that we cannot capture by studies or, let's say, genetic work, many other in vitro studies. So what you say to us is really quite important. So we need to collaborate to identify, to recognize the disease pattern, to solve the issue. And we also discussed the role of oral contraceptives and pregnancy, which may be quite important for you, because we know that Behçet's disease is usually affecting young people during childbearing age. And all of these studies are suggesting that, okay, oral contraceptives can be used if there is no known thrombotic tendency, because vascular disease and thrombotic tendency is a feature of Behçet's disease, but it's not a feature for all patients. So if there is no known thrombotic tendency, it can be tried. And regarding pregnancy and exacerbation or amelioration of disease symptoms during pregnancy, well, the data is quite controversial, but it seems that mainly it's going very well without any exacerbation, and maybe only a small proportion of patients are experiencing some exacerbation. And I believe it's mainly associated with discontinuation of the treatment because of pregnancy. So for safe drugs, it's better to keep them on throughout the pregnancy if we want to prevent exacerbations. And yesterday we also had a meeting about outcome measures, and Gülen will talk on these issues in detail, and for these measures we really need to work together. And as the last point, I will finish with the disease definition part of it. We had a discussion about, again, the inflammatory nature of the disease. So the argument was about whether Behçet's disease is an autoimmune disease or not. Well, we're actually recognizing a pattern. And what we call Behçet's disease is usually a combination of manifestations. So these manifestations may not be unique to Behçet's disease. So oral ulcer can be seen in several other conditions. Even gentle ulcer can be seen in other conditions. Uveitis, but if it is a specific posterior uveitis, the specific features of the disease, is usually very Behçet's disease specific. So some features may be specific, some may not. So we discussed with Hasan Yazıcı these patterns, but what we recognize is just a set of manifestations, different from similar manifestations. So this pattern recognition is aiming to recognize the main features. Let's say it started with oral ulcer, gentle ulcer, and uveitis, but we now know that the spectrum is enlarging, but even within this spectrum, we can recognize a set of manifestations going together, probably sharing the same pathway. And again, within this cluster, there may be some other subgroups of manifestations going together, like ocular disease or vascular disease or maybe mucocutaneous disease. But we have to recognize that there may be some similar features, but we should recognize that the overlapping features is really difficult for the differential diagnosis. You may have oral ulcer, gentle ulcer, but some other manifestations may be associated with another disease subset. So we have to keep in mind the subset of patients with a pattern. And some of these manifestations are overlapping with auto-inflammatory diseases we discussed. Well, the whole idea is actually, at the end of discussion, we agreed on that it is not the reclassification of the disease for certain autoimmune or auto-inflammatory conditions, but it's mainly understanding the disease's innate or adaptive inflammatory nature. So the disease, Behçet's disease, has a unique feature. It's in between autoinflammation and autoimmunity, especially B51 and associated immunogenetic markers are defining the phenotype we call Behçet. Well, this unique set of manifestations are defining a common pathway, a common inflammatory pathway. And if we can identify these common pathogenic mechanisms specific for this set of manifestations, that would be wonderful for targeting those pathways to develop specific, much safer treatment modalities for our patients. So thank you very much for your attention. And
how you can sum up a two-day conference in about 15 minutes, I do not know, but certainly that was a very, very comprehensive approach. We have a few moments for questions.
I was just going to ask, would it be possible for us to get a copy of that summary, of your summary?
Sure.
PowerPoint?
I'll talk to you about it if you can email it to me.
Yeah, sure.
That would be really
Yep,
helpful.
I'll try and
Thank
sort
you.
that way, yeah. That's all.
Well, thank you for your presentation. My question is about new research in biologics. Former biologics tend to attack, I think, T and F cells, or I don't know how to say it. And new biologics tend to perhaps go in the way to IL inhibitors, perhaps.
Right.
Yeah, like I don't know the name, tocilizumab or something.
Tocilizumab is for IL-6, so it's one of the key inflammatory mediators.
Yeah.
Again.
So that's the future going, the future track.
To be honest, future is targeting critical inflammatory mediators, and we know that Behçet disease is a complex disease, so there is no single target that we can use for the treatment. So TNF is a good target, and most of the drugs are working, but there are some safety issues and also cost issues. So for any biologic treatment, it's the balance between what we can have and what are the costs and the safety problems. So we are just trying to balance those issues. So because of the infection rates and some opportunistic infections, well, we are considering some alternatives. But none of them are very safe. There may be some differences between them. And for some patients, TNF may be a good target, but for others, IL-6 or IL-1 may be a good target. So we still don't know the real answer for that one. But the promising thing is we have now a different set of molecules, biologic molecules, seems helping for the relieving of these manifestations.
Yeah. May I ask you about the biosimilars?
Well, biosimilars are exactly the same thing, which are expected to be cheaper.
Yeah.
So I think it's mainly it's the issue for reimbursement authorities. It's not the issue for us. So we know that biosimilars are safe, produce high quality, but the main issue is about the price.
But not the same molecular. So
well, actually, it is more or less the same molecule.
More or less, but not
the more or less part is, nobody can claim that it's exactly the same.
Yeah.
And to be honest, in any biologic, let's say, if it is infliximab produced in the States, in Ireland, in other parts of the world, by the same company, is not the same.
Yeah, okay.
I have two questions. Aaron?
Yes, thanks very much for your presentation. You mentioned the well-being of patients and that the clinicians want to hear about this. But apart from maybe influencing behaviour of clinicians in clinic, what benefit do you think this could serve to research?
Well, for research, I think we have to remember that we are trying to find for the same purpose. So we are on the same line anyway. So if doctors are honest and the patients are honest, and if we all agree on the aim, and the aim is, of course, helping you to identify a good treatment for your symptoms and manifestations, and to get rid of the disease if possible. So this is the same aim. So a good connection, good interaction between physicians and patients are important for all research. So we really need patients' contribution. Sometimes it's just filling in a questionnaire, sometimes giving a blood, sometimes giving saliva, sometimes being registered for a clinical trial, but they all are quite helpful. So we are in the same line, we are fighting for the same target. I'm so sorry, we have now a General Assembly, and I'm the Secretary General of the Society, so I can't go there.
We're very grateful to you.
Thank you very much.
Hello, my name is Bidan Hatemi. I work in Istanbul and live in Istanbul. I'm a rheumatologist. And it's really wonderful to be here. I think these patient conventions are wonderful, and I'm very happy. Sorry. I'm very happy that this has been going parallel to the Behçet conferences for many years. I'm sure because it's such an issue, and we could have patients from Turkey, from all other places, because we learn a lot from each other when we're talking to Behçet experts who are working in Japan or in USA, in Turkey. We learn a lot from each other's experiences. And having patients from different parts of the world, happy for them help. patient.